So the shortened step length happens in the swing phase of the gait cycle, and it's caused by pain, it's caused by weak push-offs, or even weak pull-offs. So the weak push-off would be weak triceps surae, or the gastrocs and the soleus, and the weak pull-off would be when you're pulling up like that, so weak hip flexors would cause that. And so instead of taking a normal step, like so, the step would be a little bit smaller than normal, causing a faster cadence. Plantar flexion at the ankle at contact happens in the stance phase, or right in that loading phase of the gait cycle, and that can be caused by gastrocnemius spasticity, because that foot is not being able to plantar flex as much. It can also be caused by drop foot, which is a neurological sign, and then it can also be caused by any hamstring or knee joint pathology or pain. Inadequate plantar flexion at push-off happens in the swing phase because you're pushing off there, but if that plantar flexion is inadequate, then maybe instead of pushing off, it's really just going to be less of a thing and it's having to compensate on that other side. This can be because of any strength deficits in the gastrocs or the soleus. It could also be caused by an ankle sprain or any spasms in there in the gastrocs, or even any forefoot pathologies can lead to that lack of plantar flexion during that push off. Is the inadequate knee flexion angle. This happens during the stance phase or the loading phase when you're taking a step, and usually that knee is going to flex about 20 degrees or so, but an inadequate knee flexion angle is going to be less than that, and that can be caused by any sort of quad pathology or knee joint pain. And so when you're taking that step and there's less of an angle, then you're not able to get as much plantar flexion to be able to push off. Whereas if you have the correct knee flexion, then you can produce more power by being able to then extend that knee and push off. So now is the forward trunk angle. So what happens with this happens during the swing phase. Instead of being in a normal upright position when walking, you're actually gonna have that trunk tilted forward just a little bit. And this can be caused by any sort of like low back pathology, could be a herniated disc, any weak or painful hip flexors can be a cause of that, just because they'll be tight, they'll be painful, and not able to like really produce that contraction to get you to move forward. And so your trunk will kind of compensate for that. And then to go along with the kinetic chain as well, any weak ankle plantar flexion will help to contribute to that forward trunk angle, because it's trying to help, the back is trying to help compensate for that momentum that the ankle plantar flexion can't give you. So if it's weak, then your trunk's going to be moving forward and then taking that step in that stance phase. Toeing in or toeing out, that's going to be happening during that loading or that swing phase. You could say even, honestly, both swing and stance phase can have it, because you'll be doing them in like in different ways. You'll be landing differently. And so the toe in is going to be caused by more of those lateral structures, and toe out is going to be affected by more of the medial and the plantar structures. So what we know is from our hip and pelvis section is that any sort of hip anteversion or retroversion can contribute to toeing in or toeing out. Like that can be a sign of the anteversion or retroversion, just depending on what you've got. Toeing out is going to be the retroversion, toeing in is the anteversion. And so this can be caused by any sort of tibial rotation, so rotation at the tibias, moving inwards that way or outwards that way. Any sort of hip rotation, again, anteversion, retroversion. And then also any sort of excessive pronation. You can see here, if I'm pronating a lot, my toes are going out. And so that's really those medial plantar structures really going to be contributing to that. And that's really gonna be happening mid-stance. So when I'm here, and if I'm pronating, let me turn here. If I'm here and I'm pronating, you'll see, and I'm like really excessively pronating, you can see that my toes are going out, and so that's how. So steppage gait happens in the swing phase of the gait cycle, and one of the things that can contribute to this is foot drop. And so you'll see that with the toes pointing downward and not being able to really pick up the knee and the ankle. So this can also be caused by weakness or pathologies in the hip and the knee as well, again in the flexors, and not being able to clear the hip, knee, and ankle off the floor when you're walking like that. And so, like I said, the steppage gait is an action that follows from the foot drop. So the foot drop is when you can't lift up that way, and so the steppage gait is how you're walking with that. It's a result of it. So it's again indicative of a neuropathology, but when you're kind of walking like so and you're not able to really clear it off the ground, so you're really having to compensate and like exaggerate bringing that hip and that knee off the ground. Drop and the Trendelenburg gait are really interrelated with each other because the pelvic drop actually leads into the Trendelenburg gait. And so what happens with the pelvic drop is you'll notice in the stance phase that when that step is taken and is loaded on, the pelvis will start to drop on one side. And what's interesting to note is because the pelvic drop leads into the Trendelenburg gait because of weak hip extensors, so the glutes, and possibly even the hamstrings, and then weak hip abductors, so again glute medius, maybe even some TFL in there as well. You'll have that kind of continuation of the pelvic drop in the Trendelenburg gait, but the important thing to differentiate between pelvic drop and the Trendelenburg gait is that you'll actually have a trunk lean on the contralateral side of the Trendelenburg gait. And so that's kind of an important thing to note when differentiating, okay, what's the difference between the movement pattern when they're walking and having that drop, and what's the difference between them just having that pelvic drop. So a gluteus maximus gait happens in the stance phase. So after that step is being taken, it's loaded. What we'll notice with the gluteus max gait is they'll be leaned back. And so you can see I'm kind of exaggerating here. But in the stance phase, if those glutes are weak, if they're tight, if they're spasming at all, that's really going to cause the trunk to lean back, and it's really going to lead to less effective gait because their momentum's not going to be propelling them forward, and they might compensate in other ways throughout the kinetic chain, but they're really not going to be able to have a more effective swing because they're leaned so far back. Have the psoatic limp. And so this is going to happen in your swing phase where that psoas is really going to be tight, maybe causing some pain as well, possibly even spasming. And so what we'll notice with that is when they're taking that step, they're going to lean a little bit towards that problem side, and they're going to be maybe even rotated a little bit. They'll have an increased lordotic curve, so instead of their pelvis being a little bit more neutral, they might be a little bit lordotic, and then also anteriorly rotated because we know how the spine and the SI joint and the pelvis all interact with each other. And then the other thing too, I don't know if I mentioned this, is hips going to be in external rotation with that, so they're really going to be limping. I'm exaggerating here again, but they're limping towards that side, and it's going to look a little bit weird. You'll probably notice that weakness as well because they're not going to be able to flex as much either.
Shortened stance time is an antalgic gait pattern that we see, or better commonly known as a limp, where one limb is spending less time on the ground. So this occurs primarily in the stance phase and will increase the stance time on the contralateral limb and decreasing the hip and knee extension in the ipsilateral limb. So this usually occurs and will be associated with pain in the shortened stance limb or acute injuries like an ankle sprain or something that would make the patient want to spend less and less time on that limb. So with an asymmetrical arm swing, one arm will swing more or less than the other. This will occur in both stance and swing phases. As our gait, we use our arms throughout the cycle. So this will alter our center of mass control, decreasing our gait efficiency, and then it will also limit our hip or alter our pelvis motion. So throwing off, even though it's not our legs, that arm movement will very much affect our gait. And this can be associated with upper extremity injuries, spinal dysfunction, or even a leg length discrepancy. So oftentimes we might see them keeping that arm stiff or close to their body. So flat foot at initial contact is that absence of the initial foot or heel contact in our gait. So this occurs in the stance phase. It's also associated with a shortened stride and increased knee flexion at contact. So we might see the athlete's foot hovering as they're trying to start their walk. This commonly occurs with ankle sprains, gastrocnemius strains, soleus strains, or even just heel pain, anything that will kind of keep the athlete off of that foot. So excessive knee flexion at initial contact refers to the knee being at or near full flexion during walking. So this will occur during the stance phase primarily. This will increase the quadriceps demand biomechanically, causing somewhat of a crouched gait. So we might see our athlete even with a little bit of that antalgic gait with this. This will affect their forward motion, and this is commonly associated with hamstring or hip adductor strains, tight hamstrings, or even hamstring spasm, as well as sciatic nerve pathologies or just general knee pain that would cause them to stay in that flex position. Inadequate knee flexion during swing is a reduction of knee flexion causing that stiff gait. So from moving here from our stance phase into our swing, it stays in kind of that extended position. This will increase our hip flexor and dorsiflexor demand at the ankle. It will also reduce our foot clearance, and we'll then see compensations at the hip through circumduction or hip hiking to get that foot off the ground and into the next step. This is commonly associated with hamstring pathologies such as strains, spasms, or sciatica, as well as knee extensor contracture. So if the knee extensors are contracted, that leg will be stuck in that position. Inadequate hip extension at terminal stance is defined as the hip failing to reach normal extension before pre-swing from contracted hip flexors. So this will occur usually in the stance phase up to that pre-swing, as I mentioned. Biomechanically, we'll see a shortening of the contralateral step length, a diminished push-off, and then we'll see compensations of increased lumbar extension and an anterior pelvic tilt as the leg is being pulled from those contracted hip flexors. So this can be associated with hip flexor pathology, FAI, back pain, or SI joint postural dysfunctions, like I mentioned, the anterior pelvic tilt. Excessive foot pronation is defined as dorsiflexion of the ankle, abduction of the calcaneus, and eversion of the foot. This will then cause stress on the medial and plantar surfaces of the foot. This type of gait typically occurs in the stance phase, which will then delay our ability to push off, cause a little bit of tibial internal rotation, as well as increasing the strain on the plantar surfaces of the foot. Common pathologies linked with this are the toe out foot positioning, medial tibial stress syndrome, leg length discrepancies, and then at the hip we know now that it will cause a muscular imbalance, then leading to potential pathologies like coxa causing that genu valgum and that toe out position. Stiff knee or hip gait is defined as reduced motion in the knee or hip during that swing phase. Biomechanically, we'll have that reduced energy efficiency. We might see circumduction or hip hiking, and compensations from the pelvis as well. So we'll see a little bit of that kind of stiff gait that we were talking about earlier, and pathologically we would have pain limiting the joint, swelling, or even a post-surgical might cause that stiff gait. Calcaneal gait is better described as heel walking positioning. This would be excessive ankle dorsiflexion and can be seen in both the stance and swing phases. It would show a very minimal or absent push-off, decreased propulsion as the forefoot and midfoot are then brought into the air. We would also see increased knee flexion in stance to keep the person on their heels. Pathologies associated with this would be a tibial nerve injury, severe plantar flexion weakness, or forefoot and midfoot pathologies, keeping them off of that part of their foot. Short leg gait is described as one limb functionally or anatomically shorter, leading to an asymmetric gait and pelvic drop on the shorter side. This can be seen both in the stance and swing phase. And then biomechanically, we will see a trunk leaning compensation, knee and hip flexion on the longer leg, and toe walking. To demonstrate this, I have one heel on. So as you can see, the right side would be my shorter side. To keep up, I'm walking on my toe, and you do see a bit of that pelvic drop on that side. And this is typically from a leg length discrepancy, which if this heel wasn't there and this were my true height, we can see there would be a leg length discrepancy here. Abductory gait is when the limb moves in an abnormally wide arc. Obviously this is exaggerated, but in that abnormally wide arc, increasing hip abduction. This is seen in the stance and swing phase, so we would see just kind of that circular motion at the hip. We would have increased mediolateral ground reaction forces, greater hip abductor demand, and then we would also do that circumduction like I mentioned to help clear the foot between steps. This is commonly associated with hip abductor weakness, Trendelenburg compensations, as we talked about earlier in Hannah's video, and knee valgus deformities.